Me.
Yeah, I can hear you.
Wonderful. Right. This lady is a Gravida 2 para 0+1. She had a TOP in 2014. Late booker because she found out late. BMI of 19, and she is a, well, present smoker. At 30 weeks, her ultrasound scan was completely normal. And then at 37+5, she had an ultrasound and she had a raised umbilical artery PI, a positive end-diastolic flow. So an induction was booked, I think, for like 39 weeks. But in the meantime, she was having twice weekly CTGs in DAU. So she came in for her induction at 39+1 on the 29th of the month. Obs up in the corner there, as you can see, were all completely normal. Pre-PROPES, her CTG looked like this. And then on the next slide, you'll see. Actually, no, I don't think I've put the next slide in there. No, I didn't. Pre-PROPES CTG was here, so baseline around sort of 140, 145 points. PROPES was put in at 2047, and then her post-PROPES CTG was completely normal. I haven't included all of them because, bless her, she was on the on antenatal ward for quite a long time. But all of her CTGs were completely normal for the next sort of 24 hours. And then on the 30th, for some reason, it's decided to completely block me out. So literally, 12 hours later, the PROPES fell out. But she was reportedly contracting around sort of 2 in 10 at this point, so they decided not to put it back in. That was on the 30th. So we basically left her for quite a long time. And this is obviously 2 days, well, 1.5 days later now. At midnight, she had a VE and the cervix was 1 centimetre dilated. The CTG was obviously noted to have D cells present, as you can see. Midwife in charge and registrar in theatre at this point. So at 0050, the midwife in charge came to review, and the plan was to continue CTG. What do we want to do here? If you guys were on Hope Ward and this is what you saw, what would your port of escalation be? What would you be saying?
Well, that's an abnormal antenatal CTG. She needs to be transferred to labour ward.
Yeah, absolutely. We get it all the time, don't we, when we're on Hope, that, you know, we'll put a CTG on and there may be this sort of odd or very much random deceleration that doesn't always sort of coincide with a contraction, very much sort of baroreceptory, possible baby squeeze in the cord, or has its arm round it, or slight position change and it can go down, right? But here, it just makes me think, okay, we need to escalate this. This is an abnormal antenatal CTG, despite the fact that she is still, you know, she's clearly contracting here. We need to sort of do something about this. She also was vomiting. So there's loss of contact, and that's reported to be maternal pulse, where you can see it around sort of 80 to 100. So her mum's pulse probably about 90 at this point, but no obs were done. So if we're in a point where we're looking at this, on our antenatal ward, my sort of recommendation is obviously absolutely get the midwife in charge to come and review if the registrar is in theatre and is sort of unable to come round. But what I would encourage you guys to do is to say, actually, this isn't a CTG that is suitable to be kept on antenatal ward, but also she needs to be on labour ward. This is abnormal. Yeah. Whether or not she's 1 centimetre or not, and whether or not it normalizes, there's something going on with this baby here. And this is where we come back to ask ourselves that question, you know, is this baby fit for labour? She's 1 centimetre dilated. We've got decelerations. They are somewhat coinciding with contractions, but at the same time, this is giving me this could progress to hypoxia quite quickly kind of vibes. All right, although our baseline does remain stable, and it has been since the previous one, and also our variability is still normal. So absolutely, we need to escalate this. And as soon as the registrar is out of theatre, then it's much easier for them to come and review on labour ward, as opposed to leave the labour ward to go and review this on antenatal ward. Yeah. Okay. So the CTG does somewhat normalise. Hello?
I think, Clara, this is a subject that we need really, really, really to discuss. That we need a senior midwife or band 7 midwife on Hope Ward day and night, something like that.
Yeah.
Or senior band 6 at all time, because it's not only that we are having recurrence of the same scenario. We come to the CTG meeting and there is no escalation. We are having this nearly on a weekly basis. And also, not only there is postnatal incidents in Hope Ward at the same time. So more or less, I am feeling that it is not a CTG issue. We are lacking leadership in Hope Ward. And unless we have a 24/7 leadership of this ward, more or less, we will stay, as Jansen said, 20 years ago when he started in the hospital, it was called Hopeless Ward. I think it's time to change it to Hope Ward.
Yeah.
Thank you.
Absolutely, Mr. Niggy. This is a very much a recurrent event. We are getting something called fetal link, which you may have heard the term bandied around, which actually could support us with this quite a lot. However, shouldn't need to. Let's put it that way. So fetal link is a system whereby we are going paperless, so that all CTGs are going to be automatically uploaded to Cerner. To all women in the unit from every CTG machine. I think this will benefit us because not only will we be able to access every single ongoing CTG in the unit from any computer, but other people, or if we've ever got concerns and whatnot, it means that, say for example, you've got a registrar who's just come out of theatre and is writing their post-op cesarean section note, for example, and the Hope Ward midwife calls and says, I've got an abnormal antenatal CTG on Hope Ward. They don't actually have to leave where they're sat to be able to see the CTG that they need to be looking at, which I think will benefit us. However, as amazing as our technology is, and as amazing as that might be, we actually need to be able to escalate these sorts of things and act on them before they get drastically worse, and also without the idea that there's going to be constantly without thinking that actually there's always going to be somebody else looking at it, because the likelihood is, if we've got a very busy labour ward or we've got a very busy unit in general, no one is going to be able to just open up Cerner and look at every single CTG all at once. That's not the sort of purpose of it. So as great as it is, we need to try and make sure we're doing things correctly and not just relying on technology and that someone else might pick something up. But I do think that's going to help us, and that will be coming in roughly February, March time next year. So keep your eyes peeled for all the announcements and whatnot. There's an awful lot going on in fetal monitoring at the moment. But yeah,
so my question, Cara, is if we every week do the CTG meeting and find this kind of scenario, is it helpful that you initiate a datix on a weekly basis to say that there is a lack of escalation, there is a lack of this, there is lack of seniority, there is lack of leadership?
Yeah, absolutely. I mean, I'm somewhat keeping track of the amount of times that CTGs are considered abnormal. I mean, I think this is case review number 50 something now. So we're well into the we've been doing this for an awfully long time. But yeah, it's just the point of escalation, because of our sort of team and what's been going on at the moment with sort of lack of leadership from Hope Ward over the sort of past few months due to sort of job changes and whatnot. We haven't been able to have that sort of second person to look into this, which will be really beneficial when we do get someone in that role. But yeah, we will have to wait and see, essentially, and I will continue to check up on all of the things that have been going on antenatal ward overnight, basically.
Thank you.
Because it does so happen to be that all of our, well, not all, majority of our unescalated CTGs are happening on the night shift. But anyway, the CTG somewhat normalizes. Our baseline still remains sort of, it's probably about 135, 140 here. We are still getting some decelerations, but also note how long her contractions are lasting. I think in this situation, they're probably coupling a little bit as well, but some of these contractions are ongoing for like 3 minutes. And actually, if you speak to any of our obstetric consultants, or if you go to any of the additional study days as well, what you'll find is that actually, despite we always want her to have 3 in 10 or 4 in 10 in order to be in active labour, actually ensuring that there's resting tone in between those contractions is technically more important than it is for them to be contracting. She's not getting an awful lot of rest in between these contractions that we can see. So what I'd expect here is for the midwives to be documenting very clearly if they're palpating resting tone with cases like this as well. Because I think that's actually more important sometimes than saying that she's having 3 in 10, 2 in 10 or whatever. Anyway, the CTG continues. This woman has moved to a left lateral position, and the CTG does appear to have slightly sort of less decels, but those contractions are continuing to go, continuing to sort of keep going. At 02:30, the CTG was reviewed by the obstetric registrar, and this was then classified as a normal CTG. The plan in this case was that if she was for PROPES in the morning, if the CTG was normal and the ward activity allows. No specific time frame was given for this case. So what I would encourage is that if we are accepting sort of plans and having this conversation with our registrars, just to ensure that they document very clearly what sort of time frame we're looking at, and how long does the CTG need to be normal for, that kind of thing. All those parameters are really important, because it's great to say in the morning, but when are we talking about? Are we just going to continue to leave this? How much longer do we need monitoring for? And so on and so forth. Anybody disagree with the statement of normal?
My comment here is it is normal, yes, and everything, but I would have loved as well if I am the registrar on and I'm saying in the morning, it's fine, but it has decelerated before. Have I made a plan that she stays on continuous CTG? Number one. Number two, am I going to hand over the case? Because if I am the reg on and I'm concerned, or people were concerned at certain time, I think it should be handed over as well. So 2 things. One is to stay on continuous because of the previous. Number 2 is I am going to hand over the CTG or the case that I was, or somebody was concerned at certain point during the night.
Absolutely. Again, this is it's all escalation, isn't it? And it's definitely something that we could improve better on, for sure. Okay, so
can I ask a question?
Of course you can.
So if Mr. Naguib, you suggested that we keep her on continuous monitoring on Hope Ward, I'm sure you know that they will kick a massive fuss if we're going to do that. And so do you think this trace is suitable for Labour Ward, because they will not agree for a continuous CTG on Hope till the morning? This is from my personal experience.
I agree with you, Maya, completely. Hope Ward will not want to continuously have the CTG, and Labour Ward will say this is a normal CTG, it's not for Labour Ward, and that is where I am saying to Cara, maybe you were not here yet, I am asking for a leadership in Hope Ward, like a band 7 or senior band 6 in Hope Ward to lead the ship in the night, similar to leading the ship in the day. I wanted it as a 24/7 band 6 leadership in Hope Ward. If they say I was concerned at certain point, then I can leave her safely in Hope Ward for the rest of the night. And if I ask for continuous CTG, they will do it. And as Cara was saying, with the fetal link coming into action, all the CTGs will be electronic. So, and we have a lot of CTG machines. So they will not say to me, we don't have CTG, we want it for somebody else. I agree with you completely. I'm just saying, in the ideal world, at least if it is not continuous for 4 hours, if I am 4 o'clock in the morning, at least I have 1.5 or couple of hours to support me in court to say things have normalized.
Thank you, Mr. Naguib.
Lovely. So 11:45 in the morning, she was ARMable. Sorry, bear with me 1 second. She didn't actually get brought round to labour ward, unfortunately, until 24 hours post being ARMable, due to the unit being incredibly busy and very high acuity at this point as well. So just to sort of consider that in terms of our human factors here as well. So she comes at 11:16 in the morning. Blood pressure is 133/84, and pulse is 87, resp of 17, and a temperature of 37. So observations were sort of within our range. This is her initial CTG, and the plan is obviously for an ARM. This continues. So ARM at 11:55 and clear LICOR was present. Baseline remains 140, which is what it's been throughout her entire antenatal ward visit so far. I've questioned this before because we discussed this case previously, but we didn't give this woman her sort of 2 hours of being mobile or anything like that before we decided to commence Synto. So it's actually only 20 minutes later that we decided to sort of start her on oxytocin. I'm not really sure the rationale for this. It's not very clearly documented as to why she wasn't given a sort of a period of time to, allow for more fetal descent and whatnot. She was ARMable. I think she was sort of 1 to 2 centimeters at this point. So, and she's also a primate. This is very much a what some people refer to as a very dry ARM. So actually sometimes that 2 hours of, descent and to sort of let the LICOR drain even further and being a bit mobile can actually support women. But in this case, that didn't happen. I sort of wondered maybe this is because I don't know, maybe because she's been in the unit for sort of 3 days and nothing's really happening just yet. I wonder if it was a case of, okay, let's get a rush on. But actually, even if that was the case, we should be giving women the time to do so.
If you want my opinion, why people do this, I can tell you it is a human factor. It is a human factor where, sadly or happily or whatever you want to consider, people want to save the 2 to 3 hours of waiting so it doesn't happen in the night. You know what I mean?
Yeah.
So for example, let's say I will put myself as the culprit here. I am on and I say to myself, oh, I'm going at 11 p.m. as a consultant. She doesn't look like she will progress because she was prolonged latent phase and she waited 24 hours. Then I'm ARMing now. Oh, let's do the Cento now. So we give her the 4 hours. So the 4 hours finish at, I don't know. I don't know what time I am now. But let's say I'm 12 midday. I say, oh, so 4, then 8, okay, 8 hours. So by 8 o'clock, I know, for example, Maya is coming on the night. Okay, so Maya can section her at 8 p.m. You know what I mean? So it is a human factor again, not a science-based decision.
Which I totally understand, but also completely disagree with. Because
no, I'm not saying I agree with.
I know you're not.
I am saying from the point of view, like when we analyze and say, for example, I am Naguib at 5 o'clock in the morning, I'm thinking, I don't want to do a section. Let me do this. I'm telling you from a point of view, clinician on the ground, what people do and what goes through some heads.
Yeah, absolutely. No, and I think that's exactly that was what my brain went to when I was thinking about the rationale behind this one as well. But yeah, obviously, in terms of care plans and whatnot, when you're on labour and the decision is made to start Cento, or even decisions made to go for cesarean section or anything like that, this is an obstetric decision. I just kind of wish here that this midwife had maybe advocated, I think maybe is the right word, so that we could allow this woman to have a bit more time, if obviously she wanted it, because it's not actually documented. It's documented that it was started with consent, but what the discussion was prior to that is not something that we know of. But yeah, Mr. Naguib, I totally get where you're coming from. I just wish that wasn't the case with some of these cases,
Yeah, Kara.
Yeah.
Yeah, I agree with you. And even it's not really a matter of the woman, the midwife advocating, is that giving the woman that informed consent. And as you bring her from the induction, you will explain to her the process. So that conversation, that communication should be clearly documented, and the woman should really be understanding it is from this point to this point to this point, and it should be clear. And that's why we even involve the use of the language line, so that the woman is really on top of her care.
Yeah, absolutely. This lady was an English speaker as well, for sort of context, so that made our communication a lot easier. But yeah, absolutely, Beatrice. Okay, so I'm going to sort of skip through a few of these slides because a lot of it is quite samey, but Cento was increased to 6 mils an hour at half an hour afterwards. We are still having some decelerations. That Toco's not particularly working very well, but I think it's adjusted in this sort of segment, which is great. And so forth we continue. Her body responds really, really well to the Cento. Before she was on the Cento hormone, it was sort of 1 to 2 and 10, but they do pick up quite quickly. So that's always quite positive. Some nice cycling that we're seeing here as well. This baby going through a nice little sleep cycle, and then going through that period of active sleep here as well. I believe movements were recorded too. Cento is increased to 12 mils an hour about an hour later, and she's contracting sort of 2 to 3. Don't know what's going on with the Toco at the end of the CTG, but yeah, we are still getting some decelerations at this point, but I don't know if anybody agrees or disagrees to sort of keep turning it up or to turn it down. I think this baby responded very well after it was turned up to 12 mils an hour. So at 1400, the Synto was completely stopped due to a deceleration. I believe it is the one that you can see sort of smack bang in the middle of your screen, sort of lasting maybe 90 seconds or so from what our baseline was before. Good variability within the deceleration, which is something that we consider reassuring, and not prolonged or anything. But the Synto was stopped at 2 o'clock. And then restarted at 2:02. In terms of decision making, it's not very clearly documented who sort of made this decision. Obviously, if we're stopping Synto for concerns, we don't frequently start it 2 minutes later. But I wonder if maybe the thought process was this is going to be a prolonged deceleration because it lasted that sort of 90 seconds and then it was stopped and then restarted when we realized it was absolutely fine. But yeah, her observations are very much similar to what they were before. And this continues. So the Synto remains at sort of 12 throughout here. Got some acceleration still present, which is again a really reassuring sign. And we continue even further. Our baseline sort of possibly creeping up to around 150 here, but contraction still sort of 3 and 10. And this baby's showing us some lovely cycling, which is also very good. This continues. Synto remains at 12 mils an hour and she sat on the birthing ball. This lady was very keen to sort of be as active as possible during labour, and very keen to sort of steer kind of clear of pain relief as well, from what I can remember. But yeah, sat on the birthing ball here, and our baseline has definitely gone up here to around 155, if not 160. Anyone want to recommend what we might do next? Anyone want to start some IV fluids?
Also, what about her urine output and the urinalysis and her
So-
observations?
She hasn't actually passed urine for the whole time she's been on Synto at the moment, Beatrice, so that's a really, really good shout.
Her observations, temperature, respiration, heart rate?
They were all normal when they were last taken within the last hour. Her blood pressure is higher than it was at booking, but not enough for it to be medicated. And also, I think obviously taking into consideration that she's going to be in some pain here as well, you know, we can allow for sort of slight adjustments and whatnot.
Yeah, I would request a bag of fluid from the doctors, as well as encourage her to drink.
What would be your rationale for asking for fluids?
The urine output, as well as the baseline going to 160.
So what are fluids going to do to our baseline?
As much as it's not going to lower the baseline, it's going to help the woman's urine output.
Yeah, absolutely. So making sure she's hydrated being the sort of key thing here if it did come to sort of starting fluids. I think we've made it incredibly clear that fluids are not something that necessarily fixes our CTGs, but yeah, absolutely for hydration. Mum's pulse is still sort of normal, but yeah, absolutely we got to start fluid balance, specifically when we've got a woman on Synto, because we know it can sort of dehydrate our women as well. This continues.
Sarah, sorry to ask you, what was the baseline? I missed the very beginning. What was the starting baseline or the
About
antenatal baseline?
Antenatal baseline was about 140.
Okay, so we're only around like 15 beats baseline rise, correct?
Yeah.
Okay, thank you.
I want to say, Cara, as much as we were talking about not waiting for the 2 hours or waiting or whatever, and so on, I would encourage both midwifery and doctors to involve in a discussion that sometimes in this situation, we shouldn't be as midwives trying to encourage women to say, oh yes, stay on the birthing ball, oh yes, stay without pain relief, oh yes, stay without a catheter, because we are promoting normality. Because in some occasions where we are starting Synto, sometimes having epidural and catheter and relaxing, like has an effect on some progress. Yes, it is not progress because of epidural is making progress, but only because the lady is not feeling so much of the pain. So if in this situation you would say, she doesn't want, we need to also discuss that possibly relaxing, possibly a catheter, because although some people here say she's dehydrated, they might not be able to pass urine, rather than simply assuming she's dehydrated.
Yeah,
If
absolutely.
you want to think that she's dehydrated and bladder is empty, then maybe a bladder scan. I don't know. Just don't think she is dehydrated and just put IV fluid, because there is other things, or maybe a bedside scan. So there is more to the progress of labor and the art of obstetrics than just starting and stopping Synto, and encouraging from the obstetrician side and from midwifery side, encouraging normality, as they call it. So neither this nor that. It is something in the middle.
Absolutely. Again, we're bringing it back to talking about the whole clinical picture again here, aren't we, as well? Which I think we sometimes kind of lose sight on when we've been staring at a CTG for a long time. And this is where fresh eyes comes into consideration as well. I presented our audit today, and it was interesting to get some sort of feedback, but our fresh eyes assessment is a risk assessment that we should be doing hourly. So these sorts of things can be encouraged whilst we're doing our fresh eyes. So,
Cara, the Synto causes fluid retention, not dehydration, correct?
Yeah.
So why did we we can't assume that she's dehydrated, because as far as I know, once we start oxytocin, we do, drug induction of fluid retention. So I think we can't assume that Synto causes any dehydration. I don't know why I heard that just earlier before Mr. Naguib has commented. But Synto, I'm sure it causes, correct me if I'm wrong, it causes fluid retention, not dehydration.
You're absolutely right, Mara. I think I just said it wrong.
Okay. And one more thing. I can't because now for the past
antidiuretic,
for the past 10 minutes I've been trying to locate where, I'm sorry, this is a very stupid question. Where did the 2 hour, 4 hours, which guideline? I'm trying to review all the guidelines to see where I can't pinpoint where the 2 hours, 4 hours came in, and maybe any of the other registrars or you, Cara, or Mr. Naguib can remind me which guideline was that. I can't locate it.
The 2 hours, 4 hours, what, post ARM or?
Yeah, I just can't find it in any guideline. I'm going back and forth on my phone. I can't find it.
Oh.
Yeah, it's not in any guideline, Maya. It is a kind of like going with that ARMing increases the contraction. But it is not that like you follow a guideline, you see what the body does. And what we always, So tell me.
Because I'm trying to think of the person, because we are trying to criticize why that person did not start Synto. If somebody has been, we're trying to induce for 3 days and there's not a single contraction and you've just ARM'd and you feel this body is not responding, would we be doing, you know, something majorly wrong against guidelines? I mean, I can see the rationale of the head
No.
It's not a miracle thing. Yeah.
No. It is not. It
so
is
actually,
not
it's not
against
strong with
guidelines.
that. Yeah. Yeah.
No, it's not against guideline. What I'm saying is you are giving. It doesn't have to be 2 hours. It doesn't have to be 4 hours. That's what we always say. It doesn't have to be 1 hour. You just, as again, as an obstetrician, as a midwife, see the reaction of this human being body.
Uterus to the
ARM.
Okay.
With the ARM, usually they say 2 hours for the sake of unifying things rather than set in stone. No, it's not.
Okay, thank you.
I think I'd also hear.
Cara, you're muted.
Am I?
You were saying something.
Oh, can you hear me?
Yeah.
Yeah, we can hear you now. Yeah.
Oh, just as a sort of side note from that though, I'd love it if someone could find me a piece of research, because it's not something that I've necessarily gone looking for, but it's nothing that I've ever read. We give women an hour for passive descent when they're fully dilated to sort of aid with, you know, gravity and whatnot. But actually, has anybody ever audited how much further a baby moves down with that hour of passive descent? Like, does the station of it change and whatnot? I'd just be interested if anybody had any research on that, because I think a lot of obstetrics, like Mr. Naguib always says, is very much an art. And actually, a lot of our sort of nice guidelines and whatnot, they're not necessarily based off of really substantial evidence or any kind of research. So there's lots of things that we do, and it's just kind of protocol, but it's not actually heavily researched and proven to actually benefit in any kind of way.
So for the passive descent, Cara, it's not aiding gravity.
No,
because
I mean,
if you want to aid gravity, you need to put to hang the lady, you know, from her waist or something to the ceiling. No, but it's not. Is allowing a passive descent with the contractions rather than anything else. So yeah.
What I mean is that we always sort of sit women up, or we move women into different positions, and we always sort of say to them, oh, well, gravity is going to be helpful here. Obviously, the contractions are going to bring the baby further down for that hour of passive descent. But I've never read anything that actually has researched that and has actually proven its benefits, if you know what I mean.
Yeah, no, I agree with you in a sense that 1 hour, 2 hours, 3 hours is not. So what they found is if you leave her fully dilated for many hours, and this is based on evidence from some parts of sub-Saharan Africa where you leave the head in the pelvis for example, days, it causes fistula by causing necrosis. Similarly, once she is fully and the head high and she is contracting on her own, you can allow the passive descent, meaning that, okay, she reached the full dilatation, good. So now that the cervix is completely retracted, as they say, from the retraction rather than anything, you allow the contraction to push the head down the pelvis. So this is, again, evidence-wise. But if you leave it 90 minutes, for example, if you leave it with epidural, 2 hours, so all of this is a protocol, as you said, but it helps with the contraction. And that's why people start Synto sometimes in the second stage, where the head is still up, to increase the contraction to allow the head to come down. But again, it is not set in stone. Like if it is an hour and it's an hour 15, an hour 30, it's okay. But not 4 hours of passive, not 15 minutes of passive, because it has not done anything. So you know what I mean? So again, it is the actual situation. It's actual VE. Where is the pelvis? How is the pelvis? Is it really wide? Is the bladder well drained? Is there is no caput? There is no molding. So it is all the parameters together rather than just a simple following. And again, this is what we try to tell all the colleagues, that it is not only because you try to leave them to have a passive descent from -3. How much passive descent is going to happen? Because the fact that she's fully with -3 is that the head is too big for the pelvis. Yes, if she's para 5, it might happen, you know, like especially in the more or less in the African pelvis, where it just moves into the actual curvature. It happens, and yes, but not in every single ethnicity.
Perfect, thank you. So it was at this point, so Sinto is still on 12 mils an hour and she's in a sort of standing up position. This, from what I can see, I can see decelerations with pretty much every contraction here. And they are sort of slower to recover as well, back to the baseline that we've now gone up to about 155, 160 in the majority of the areas. This continues for a little while, but since she's standing up, actually, it seems to somewhat improve. Again, our variability is still normal, which is reassuring. But this continues for quite a long period of time. So midwife in charge comes and reviews at 17:10 and says to stop the Sinto. Anyone want to comment as to why they think that might be the case?
The increase in baseline?
Yeah. So it's on 12. And already in this case, we've had a lot of sort of stop start. Whenever you're considering the fact that obviously there is a baseline rise, this baby has released the catecholamines to sort of work with the increased need to sort of compensate itself, but at the same time turning it down is alternatively an option, because all we're going to do is then restart it once it normalizes, whereas actually we could find a very much a happy medium in this baby. So the Sinto is stopped, and a bag of Hartmann's is now started, and then sort of less than 30 minutes later, the Sinto is restarted again on 6 mils an hour, and the plan is to sort of wait and see. We did see some recovery from, obviously, you know, there is a difference here. The baseline looks like it's coming down slightly further, and there's not as many decelerations, but we possibly could have achieved this if we'd have just turned it down in the first place, as opposed to keep stop, start, stop, start. Sinto is one of those medicines that's actually, you know, it's quite strong. So once we're sort of playing around with it.
Yeah, I agree. It would have been good for us to have it like 6.
Yeah. So it's on 6 mils an hour here. At 18:03, this is now our sort of 6 hours post Sinto starting. Her examination is performed. She's 2 centimeters dilated, and the Sinto is increased to 24 mils per hour. I believe that break there in the CTG is for her to be able to go out to the toilet. Observations, as you can see, pretty much exactly the same as they have been so far. Very much sort of baseline observations, no major changes. And then the CTG, the Sinto is decreased down to 12 mils an hour, again, due to variable decelerations. She's contracting well here. From what we can see in the CTG, there's good resting tone, although that's not reported in the maternity notes. But we continue. So still on 12 for this sort of segment. Baseline looks like it's coming much back down to where it was originally, sort of closer to 145, 150 here. And we have got the odd sort of very much baroreceptor type deceleration, but these aren't sort of evidence of hypoxia for this baby. This continues again, so baseline looks like it's sort of coming back down to where it was before, and this continues for a little while, as you can see. Very much baroreceptor decelerations with these contractions too. And she's contracting well, sort of 3 to 3.5-ish in 10. Which continues and continues and continues. At around 8:30, we're seeing some more decelerations with those contractions. They're becoming a bit more frequent again. I believe the Synto remains on 12 mils an hour, which then continues for another sort of half an hour. At 21:10, she's examined early due to decelerations and CTG concerns here, and she's found to be 3 centimetres dilated. This woman has now been an inpatient on labour ward for about 10 hours and has gone from sort of 1 to 2 to 3 centimetres in that period of time, and has now spent around 9 hours on Synto with no epidural. So the obstetric registrar comes in and has a conversation with the woman and discusses the option of having a cesarean section or continuing with the labour. And the Synto was stopped. I'm not really sure why. It's not documented. I don't know if she went out to the toilet in this sort of gap that we've got here. But this woman was very keen to proceed and have a normal vaginal delivery. So the obstetrician that was speaking to this woman was very much, you know, open to going with this woman's wishes. Baseline still sort of around 150. And the Synto was stopped at this point, I think, whilst she was making her decision. I'm not really sure why. I don't know if any of our obstetricians can shed light on the reason that this may have been the case.
Sorry, Cara, what the case of what?
As to why the Synto was stopped whilst this woman was making her decision or having this discussion, or even why it was stopped based off of the CTG, to be honest.
I don't think there's any obvious reason, to be honest.
No, just didn't know if anyone was seeing things that I wasn't. So it continues. Her blood pressure goes up to 155/77 with a pulse of 100 and a respiration rate of 20. Temperature's not recorded here, which confused me a little bit, just based off of those observations. And then at 10 p.m, the midwife in charge came in to discuss the need for cesarean section. The midwife in charge had a different opinion to the registrar and was actually looking at the overall clinical picture. This midwife in charge was of the opinion that progress would have been made at this point. However, I had the same sort of discussion with this woman and the client decided to decline. Synto wasn't restarted at all in this time frame. We then have some more decelerations with contractions, although the Synto's not on at this point, and the anaesthetist comes into review. So I'm assuming at some point between the midwife in charge coming in and the half an hour later that the anaesthetist comes in, this woman has decided to go for a cesarean section. Which then continues.
Sorry, Cara, what was the last VE? What was the
Pardon?
last VE? What
The
was
last
the
VE
last
was
VE?
3 centimetres.
Okay, thanks.
Anaesthetic review here, and then this woman was consented for a cesarean section at 22:51. Anyone have any differing opinions?
We're not even in established labour. She's
Mm.
contracting. The baseline is the same as it was in the morning. The only difference is that her pulse now is 100. So there is an element of developing choreo, but the variability is fine with a stable baseline. I can't see a very clear indication. No, I can't even call it failure to progress. So she's not in established labor unless, like, I'm missing something.
Nope. Would you do anything differently, Maya?
I mean, I would give her, she is now contracting on her own, isn't it?
Yeah.
If you want to call it failure to progress, maybe you can give 2 more hours. And then if the choreo becomes more obvious, then you have something to base yourself on. But I'm not sure, was there anything else on the labor ward activity-wise, or?
It was
like at this stage, it's not very justified. I think not very obvious why the indication was there.
Perfect.
I don't know if anyone else has got opinion, can help.
Mr. Naguib?
Similarly, no idea why the decision was made. But for me, I'm the registrar on. At 10:30, this woman started Sinto, possibly with my previous night. And I'm coming from, let's say, I am Wednesday night, Thursday night. So I left her in the morning, and I coming in the night of Thursday and find her again. It's not always a nice encounter to see the same person. This means somebody who has been on Sinto for so long. And stop, start. We have missed the boat. We didn't relax her by some epidural and catheter. I mean, if it was me, I would go for a section at this point and finish the dilemma and finish the saga of and the misery of the baby and the mother and the doctor.
Yeah, but it sounded from Cara that we were trying to convince her for a section, like when she said about the midwife in charge, like she was trying to convince her that we have to have a section. Is that correct, Cara? You mentioned like
this is the kind of impression that I got from the documentation.
I can't see that this is, we have to have a section. No, I think, like, especially if she's incredibly keen. I mean, sometimes you can tell that a woman is going to deliver vaginally from the minute that you start induction. But I mean, not that I have to go twice and convince her. Might have waited for another 2 hours, to be honest.
But if we wait, to be honest, we wait. No, I don't want to say it in this way, but in one condition, we give her epidural, we put a catheter, and we try to rectify the dysfunctional labor that happened. I'm not saying she is failure to progress. I'm not saying she is abnormal CTG to be sectioned, but we are in a dysfunctional labor, or on a not a complete dystocia, I would say. I mean, there is a complete dysfunctional labor here. Uterus is not functional with me to continue. So if she wants to help me and have epidural and the catheter and possibly Sinto again, I can wait another 4 hours. But if she is not willing and she wants to bounce on the ball with a 500 mils in her bladder, then I think spinal and cesarean.
Thank you. This was her theatre CTG. 23:28, the spinal was put in, and then just afterwards, they were unable to auscultate the fetal heart rate. So 21, 28 is where you start to see the loss of contact, and then all of the loss of contact that happens afterwards was actually believed to be a deceleration. The midwife in charge came in to sort of see what was happening at around 6 minutes post, and then the registrar wasn't actually informed of this until 10 minutes after. Again, just going back to our escalation, people are very much of the opinion, oh, we don't know when to call the emergency bell. I don't like to call the emergency bell. I'm worried I might not call the emergency bell for the right reasons. If you are ever in doubt, pull the emergency bell, because it's so much easier to turn it off and to walk away from the situation than to come in and a situation have to be an awful lot more traumatic for the woman, and a lot more stressful for all the clinicians involved if we delay it this period of time. The baby was delivered 10 minutes afterwards, but it is believed from all of this that that this may have been a deceleration that started from the second the spinal pretty much went in.
Yeah, the BP also is 91/41.
Yeah.
Yeah, it's very obvious. Her blood pressure before was 150 something, and now it's 90. So definitely the baby is going to feel this. But also the anaesthetist need to be able to help with that, not wait 10 minutes.
Yeah, absolutely.
Because it was very, very obvious what happened here.
Yeah, anybody can pull the emergency bell. Quite frankly, do you know, this, yeah. Would anybody like to guess the APGARs and the gases of this baby?
If we didn't have this acute, because obviously you're calling it a 20-minute acute, you know, kind of like because of the deceleration, which lasted more than 15 minutes. If we didn't have it, I would suggest 7.2, but now you just have to calculate 15 to 20 minutes from 7.2 and subtract 0.3 per minute, isn't it?
0.01 per minute.
Yeah, sorry, 0.01 per minute. So 7. I'm trying to do the math. 7.
That sounds about right, yeah.
I'm just trying. So before the deceleration, it would have been 7.2. So I'm trying to think from there. And our misery, Clara, what is it?
Unfortunately, even lower than that. This baby was born with APGARs of 3, 9, and 10. Arterial pH was 6.92, base excess minus 12.2, and a lactate of 10.3. I think these were the same gases, in my humble opinion. Acute hypoxia, you know, the CTG did not warrant both of these, arterial and venous, to be this low. I think these were from the same vessel. There is a 0.03 difference, but that's not always the definitive answer here. He was born floppy and not breathing, but responded well to inflation breaths, and was luckily crying by 2 minutes. This baby had a normal neurological exam after being stabilised, which actually met criteria for cooling at delivery, but baby was admitted to neonatal unit, and the repeat gas that was done within an hour, this baby's gas was 7.2, which was fantastic and all we could have asked for, really. So yeah, obviously in an acute hypoxia, our arterial pH is an awful lot lower than our venous pH. That's kind of how we tell, which is unfortunate that we didn't really see this as a perfect example here. But yeah, perfect example of a sort of acute hypoxia and the repercussions of it, essentially. This baby's also very, very small on the 1.1 centile, so was much more likely to deal with the stress of that acute hypoxia a little bit worse than someone that than a baby that was normal sized.
So to be honest, the baby with this IUGR coped very well with labor, considering.
Yeah.
Yeah, so I think the baby has done very well until we exposed the baby with extreme, you know, stress of labor.
Yeah.
But I think, yeah, the baby was coping relatively well before the event.
Yeah, absolutely. Perfect. Does anybody have any questions?
No, but I will try to look for some articles regarding the questions that you raised earlier and regarding the 2 and 4 hours. So I will try to do some homework and then forward them to you. And if anyone wants also to join the search, then we can have some chat about it next meeting as well.
Sounds perfect, Maya. Thank you.
Thank
you. Just to answer a question that many people will say, because I asked already to one of our anesthetists whether preloading that happened in the past will help in reducing this kind of acute hypoxias. I forwarded my question to Sam, our anesthetist, and I asked him why we stopped preloading. I remember one of the best anesthetists I worked with in Kingston, really, Dr. Richard Stacy, and he was always preloading any woman with a liter and a half of fluids before. And we never experienced that. Sam kindly, and he is a very nice anesthetist, forwarded to me about 10 articles, all dating between 2019 and 2022, really, saying that there is no evidence for preloading. So I just want to answer this question that comes to the mind of any midwife and any mind of obstetrician, saying why we stopped preloading. They have no evidence as anesthetists supplied by them. Yes, we still see it because they don't preload, but we don't have anything to do.
That's really interesting.
Thank you so much, Cara. It is absolutely lovely case and helps us understand more the link between obstetrics and dynamics of labor and the actual descent of the baby and the Cinto and the ARM. And as Maya said, it will be good to search some subjects that we talk about a lot and see some articles about it. So we also practice evidence-based medicine. Thank you so much.
Thank you. Thanks,
you.
everyone.